Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started.
Welcome to this episode of Thinking Thoracic. I'm your host, Jeff Yang, and I'm really excited to introduce you all to Dr. Rob Hedrick, who is the Chief of Thoracic Surgery at CHI Memorial. He's going to be talking today about his incredibly innovative and inspiring mobile lung cancer screening program in Tennessee. Of note, Dr. Hedrick in 2019 received the STS Key Contact of the Year Award for his extraordinary efforts in advocating for the specialty, and we're really excited to have him today.
It's great to be here, Jeff.
Thank you again, Dr. Hedrick, for joining us. I started hearing about your mobile lung cancer screening program, I think at least 4 or 5 years ago. And I'm really excited to learn more about this. And I'm wondering if you could just share with us what motivated you to get involved in this work and what prompted you to develop a mobile lung cancer screening program in Tennessee.
I'll try to make it a short story, but my degrees in college were engineering-based sciences. I always liked problem solving. I think all of us, when we got excited about the National Lung Screening Trial, the data, the hope for lung cancer patients that just hadn't been there. Certainly, I'm 60, so my journey, my dad, who's a cardiothoracic surgeon from the 60s and 70s and 80s, frustrated with lung cancer. Amazing news, should have been on the front of every newspaper in the country, and yet nobody was. The next day just went on like it was a normal day, and patients weren't coming in. And on a trip to Mississippi, I was talking to my wife about it. So I have a advisory team of my wife and 3 beagles. And sometimes they make things look really simple that I'm making too hard. And we narrowed it down to there's a messaging problem of how do you get medical information out? And clearly traditional means of newspaper, print ad, TVs wasn't working, and they're going to ignore it. Billboards definitely don't work. And even our own medical communities were poor distributors of that information, primary care docs, family practitioners, because it hadn't been disseminated. It hadn't reached their level to be able to communicate and get their buy-in. And the second piece that was my wife pointed out to me, she goes, you have a listening problem. You're not listening to your patients. And I go, what do you mean? She goes, people will wait only a certain amount of time when they're not symptomatic, they're having a good day, and they don't want to hear bad news. They're going to turn off a TV program that's depressing. They're going to go do something that's more fun. And you're trying to drag them back into your world, which isn't always that exciting. So you got a certain time limit of how you're going to do it, and expecting somebody to drive, particularly in the rural communities that we serve, an hour to see you, they're just not going to do it. They will if they have cancer. They will if they have a heart attack. They can't breathe. There's a broken bone. Turns out that when we look further into it, people will give about 7.5 minutes, which is the time they'll wait for a McDonald's or a fast food meal, for something they really don't want, but you're kind of talking them into. On the way back home from that journey, I'd sat there at the liar's table in Mississippi, and all the people who were, I'm told, don't care about their health and don't want to live, would ask me medical problems all morning long. They'd buy me a cup of coffee and a sausage biscuit, and I'd be answering things, a lot of which I had to look up on Google. And I had a revelation of they do care. I got to come up with a solution that's not our same healthcare system. And I wasn't sure it was work. I have to go to the people. I got to make a big enough entrance into their town, community, or something that people go, what is that? What's going on? And now I have permission to tell them about lung screening. And that started this whole process that I thought was just a local way of how to get attention to something that I needed a way of distributing the good news about lung screening. It's turned into certainly a whole lot bigger journey than I had thought would ever occur.
Thank you. Well, that's a great start to this amazing journey that you have continue to inspire us with. And I was wondering if you could speak a little bit about the Breathe Easy truck. So to tell the listeners about your mobile lung cancer screening program.
Sure. So one of the things as we chatted a little bit before this podcast, my eyes, the discovery, our journey, yours and mine, and all of our uh, uh, fellow um, physicians in this have fascinated with the journey we've seen in the operating room, things that we can do as human beings, the technology. I think my eyes have been opened up so much more getting outside the operating room of what else we can do, not just in policy issues in Washington, D.C., but things that we are problem solvers. And this is certainly something that requires more than just our surgical skills. So as we got back from that trip in Mississippi, I'm going to go buy a mobile bus. There's mobile everything. Why can't I do mobile lung screening? Except there wasn't one to buy. Nobody offered one. Everyone to sell us one, but there wasn't a way of purchasing one with any data. How much does it cost to operate it? So in the roundabout way, I put my business hat on and said, all right, let's put a business plan behind it. Let's be willing to fail, but let's build one that everybody has risk in it. The vendor, the hospital, the patients, me. And we made tons of mistakes, but basically took a cheap Winnebago and threw an old CT scanner that we already had in the bus. And with all the design issues that were wrong and challenges, it still succeeded. So I go, all right, this is something that's sustainable, can live on its own. The patients will embrace. What was shocking was after the initial article was published in the Annals in 2020, the media attention and people grasping on it was unpredicted. Of news interviews, Sirius Radio, not me, but the concept that somebody came up with an easier way to get healthcare, and that we're going to put the patient's time above even the surgeon's time. And that really jump started the process. It gets billed everywhere I go as the easiest doctor visit. But we've shown that we can use modern tools. What it's also kind of led into is design changes. How do we mass produce or get other institutions to do what I've done that may serve their communities? We've had this aha moment of lung screening, unlike any other screening test, is really looking at a lot of things in the body. And if you look at what our specialty impacts in most states, somewhere around 45% of all mortalities are going to be related to what you and I do from the heart and the lung. And the economic impact, the survival impact to our states, our government, our federal government. Holy cow, we just uncovered the simplest test that's looking at a population that's asymptomatic. So we're screening people who have no symptoms. They're that 50-year age group and older, not going to the doctors. Most of these people have quit going to healthcare. It's too complicated. We're bringing them back in, but we're also seeing what their heart looks like, their coronary arteries, their lungs, how bad of, just not saying they have COPD, but what's their risk of being admitted this year for influenza, pneumonia that will take their life, or lung cancer risk, and finding things that you and I see tumors now that in my career, I've never seen tumors this small in lung cancer. It's really opened up a different way of medicine and a messaging that fixed the messaging piece. The patients, they see the truck, they know what it is, they ask questions. It's a curiosity. The ones who've gotten on the bus turn around and become your advocates because it's so easy. They go, how do you get the results in the same day? How did I have to? I mean, we have it down to the time you fill up your car with gas or that McDonald's meal that was our goal. Healthcare can be that simple and that meaningful. So it becomes something that I think innocently we stumbled up on that would help a lot of other regions of the country that have the same geography challenges, the same population challenges, the same lung cancer and cardiovascular risk that we have. And maybe it's even bigger than lung screening.
Great, thank you. I think that's amazing, really, what the impetus and what really drove you to do this. What I'm curious about learning more for both for me and also for the listeners is with regard to how many patients does the bus see a year, and where do you guys travel to, and some logistical hurdles that you've had to overcome in the years, maybe some tips and tricks for anybody
Yes.
who's listening who wants to learn more about how to
So
get
is
to
it
know you?
the biggest thing how I help other programs who have reached out. We've got more than our bus on the road now, and it's starting to grow. We've had from our own STS members, I think 51 institutions requesting help in planning it. We have actually through the Thoracic Surgery Foundation, a surgeon from New Orleans coming up to actually let me do the business modeling and teach him how to go back to New Orleans and and develop a program for that geography in that area. So I tell them I've made every mistake you can make. And I just said, you're going to hear, I apologize a lot, but I go, that's part of being sticking your nose out there first. But in all that, it still succeeded. So in the original goal of, I said, to me, screening is a high volume number, just getting the messaging out, but not really helping people and decreasing mortality was not success to me. I wanted to do both. So the bus had to be sustainable for at least 10 years from an engineering design. So I put my engineering hat on and said, all right, I used all my degrees, and we corrected all the things that I instantly didn't know about that makes the bus more rugged. The CT scan technology was surprisingly really robust already and didn't have to have a lot done. But the throughput, just getting people on, the organizational structure, we needed it down to that 7.5 minutes. So our goal was 3,000 people per year on the bus. We would try to offload them to brick and mortar sites. So the bus kept having that same capacity, and it was really constantly doing the messaging piece and the visibility in the communities. We learned we can't go more than an hour and a half, and really an hour is your sweet spot. And even though we were hitting the rural communities, we found within 5 minutes of our hospital were populations of minorities, whether Hispanic or Blacks, that don't engage in healthcare, that we had opportunities to come into their communities and do healthcare in a different way, build that trust and let them engage in something that was simple. So you get too far away without a partner, then you don't, you start creating complexities for that patient, and maybe you're not serving them well. So this year we hit 3,000 and some change on the bus that's currently in operation. And we actually think that capacity is higher with some of the AI tools and some more lean principles. We think we get the visit down to about 4.5 minutes. So on and off the bus, next patient on, and create this throughput consistency, which is high volume screening and getting the same results to them the same day. And what that does from a patient standpoint is they turn around and go, because we do such a terrible job in healthcare with all those things, they'll go out and sell it for you because it's shocking to them it can be done. Shouldn't be to anybody, but that's the good part. What challenge we had is once they get on the bus, they will not go to the brick and mortar place. They'll go, I'll wait for the bus because it's least disruptive to their lives. And this is an asymptomatic patient, not somebody sick who will wait for any scan any day. So we realized that we need a second bus, which is what we've just received. And we're going to use a different strategy of maybe not as high volume seeking, but trying to get into the really stubborn populations that don't trust us as physicians or the healthcare system, and spend more time with them to see if we can break through some of those barriers. And that's the partnership we have with the GO2 Foundation on this current bus. So we're learning it. It's so far has worked out. I think a challenge that we're seeing is with interest has driven up. Now, how do you produce these buses quick enough and get them out? There's no one way to build it. I don't have any financial stake in it. I just had engineering input, and I want to see this work. I also think that, like in our geography in Knoxville, Tennessee, just up the road, which is where our bus kind of was helping them out, but we needed a partnership with them. They're now getting ready to have their bus built and are going to engage in it. So we'll work together. I don't care where the patients go, Knoxville or Chattanooga, but the fact that they're out there doing it and we're out there doing it, now it's easier to get lung screening done. More people know about it. Home Depot and Lowe's always build together because that synergy actually makes them both better. So this idea of hospitals and thoracic surgeons and communities working together, lung screening will make us all better. And it's one tool that I think certainly has engaged us with the University of Tennessee Health System and a relationship that our hospital hadn't had. And it puts the communities together and the goals together. And it just came back to, it took this little bus on wheels that came from my wife and trips to Mississippi and my three beagles to say, get out of the operating room and do something different. That hopefully gets this lung screening to a place that we're really making a difference.
Great. Yeah, I think you are already making a tremendous difference. And it's very impressive that every year you're screening 3,000 patients all across Tennessee. Can you share with me some of your experiences out in the community? I remember
Yeah.
before the podcast, we talked a little bit about you going out, for example, to one community and the people there, how the bus touched and affected patient lives.
So the backstory on how all this actually came about came to my hospital CEO with an idea, and she gave me what my parents learned not to do. Well, if you go raise the money, you can do it yourself. I want to take flying lessons one day, and my mom said the same thing, and she regretted saying that. I became a pilot, but so I went to a donor, and 2 weeks later, I sat back in the CEO's office, and I go, I have the money, and he had this shocking look on his face, and was like, okay, crap, shouldn't have given a cardiothoracic type A personality to do this. But we started truly a goal of metrics, willing to fail. It had to cash flow itself. I mean, it needs to be to stand on its own, whoever's paying for the bus. Second, the design had to last 10 years. The 3,000 people capacity wise gave us a way of reaching our goal in our community, or at least the bus helping us reach our goal of how many people we need to screen to really make a difference. And it's in the 20,000 range. So with that, we also picked a town that we knew we could change if this concept worked. So it had to work for the patient. Spring City, Tennessee, a small community in Ray County, one of our 95 counties in Tennessee, has a primary care doc who's the jack of all trades, pediatrician, adult doctor, gerontologist. She's the cook at the school events. Great Doc Hollywood, exactly what you anticipate. And she wanted any help she could get. So she became our target. They have a high prevalence and mortality rate for lung cancer in our state, one of the highest. And it was a population size that gave us 5 years as a realistic goal. Could we change that community? 5 years later, lots of phone calls of so many things we did wrong, and just messaging, getting reports back to her, coordinating things. She called me and she goes, you don't know what you've done. And I said, what do you mean? And I said, give it to me. I got thick skin. You were our guinea pig. It's just, I appreciate your patience. She goes, no, you've changed this community. I go, what do you mean? She goes, we have 12 people with lung cancer walking around alive. They haven't seen one. This is a community of, 2,000 people, less than 3,000 people. And she goes, when one person dies, everybody in the town knows it. And lung cancer has such a negative stigma that people just don't live. You get it and you die. She goes, so not only do they see that, she goes, how many times have you been up here? And I go, well, since the police gave me the speeding ticket, none. But she goes, no, you and I don't put these events on anymore. The patients put them on. The survivors are out there getting other people to get lung screening. And you've seen this, and it took a 5-year journey. The first couple years are really tough, that it sort of sells itself. You'll find winners, you find the survivors, you find the early disease, and you change because of those people will be your people out in the community saying what I need to say, which fixes the messaging problem we had with lung screening to begin with. But it's not 1 year, 1 day. You can't go and just give one talk. It's been a fascinating town to see. And what's cool about it, and what you said, you and I are now not the drivers. The people in the community are driving this change. And all this, there's not enough of Jeffs and Robs out there and everybody else to do this on our own. We really need the survivors in lung cancer to go tell the story for us. They're the ones that have even a different platform and a listening group that will make a bigger change than you and I saying something. And that's really, I think, what has helped create.
I completely agree. The importance of lung cancer survivors telling other people about the importance of early detection. And what you have done is really drive that in all of these communities, which is incredible.
Shown
Go
as
ahead.
possible. What I need and what we're trying to do help is, okay, here's just one idea. It's not the only solution to lung cancer, but if we get out of the operating room and people that this fits for their geography, their region, or their approach, I go, it's possible to change the stigma, the perception around lung cancer. We just got to do it in some different way than you normally market or advertise or message things out. And this is just one way that worked. How can we scale it up?
Exactly. Now, let's go to some nuts and bolts. What does the Breathe Easy bus need to succeed? You talked a little bit about gas and you need somebody to drive the bus, but can you talk about what the team looks like?
So I think the biggest component is whether you use diesel fuel or whether you use all electric. It doesn't, to me, I don't get in the weeds on that. Pick your choice, change the cost. There's different risks that go with both. There's a cab and tractor trailer model. There's what we have, we felt this design was a little bit easier to get around in the rural communities and mountainous areas we have to go to. But it has to be temperature controlled, humidity controlled, and there's got to be a process where you're creating a safe space for the patient, the CT tech, the people on the bus. This also has a good market of CDL drivers that drive the Coke and Pepsi trucks that are well experienced at it. They're tired of doing all the manual work, but still want to use their skills at driving. It's got to have a way of communicating back to the hospital. So to get the results to the radiologist to be read, Starlink is probably the most impressive thing we've all seen and heard in the world recently. It is that fascinating, and it's not expensive, cheaper than cell phone towers. So we had to use multiple companies, AT&T and Verizon, to get our messaging because of different towers in different regions. And we made it work, but you got to have a communication both to the hospital, but also to the bus. So from to the bus, we have Epic as our software, but whatever electronic health record you're using, you need to communicate back to our office, the lung screening office, the hospital. And we're using registration help that's more abundant there, so that you're limiting who you have on the bus. Communication is important. Whatever you need, a reliable platform. They have to be repaired or fixed in whatever community you're in, because you're building one or two or three of something, not like a GM or a Ford assembly line. So we pick diesel because of the diesel mechanics and the access to repair. You've got to have a motivated team, because early days are hard to get people to know what you're doing, to take advantage of the opportunities. But if you just stick with it, the patients will sell it and it'll take off. The CT scanner is not that big a deal, but you need an AI tool with it. That is the big deal. It speeds up the reading and allows you to capture all the cardiac data that is meaningful to these patients. My father always knew, and very bright, pioneer in cardiothoracic surgery, knew he was going to die of lung cancer, and there's nothing to do about it. He smoked his whole life. He died of a heart attack. If we forget about the heart that's sitting on these scans and these patients, we're not doing them a complete service, nor our healthcare um, policy side of it, that we're not looking after the patient's true interests. So to do that and do it quickly and make it simple, these AI tools are just so prime for that area. And there's so much more data you can extract off of that scan to help us in managing them. I think from a nurse practitioner, somebody has to be responsible for them. So we run this as a centralized program with a thoracic surgeon at the top, and then a nurse practitioner that's doing the reporting, getting that messaging out. We use text messaging back to the patients. So the reporting system and technology, so the feedback's connected, and there is a accountability to not just the lung findings and pulmonary findings, but the non-pulmonary findings. And I think from my practice and what it does do for a thoracic surgeon, it puts us out in a different spotlight, that people see us in a different way. We go to Christmas parades with the bus, where I'm giving talks in communities. They get to see us as human beings, but also we care about them. It will also put you as the expert in lung cancer, which I think we've never abandoned lung cancers, especially. It also puts us in charge of that patient. So you're managing their life. Maybe their coronary artery disease that you didn't want to, but okay, it's important. But also with so much that's coming down the future pathways for lung cancer, now we're treating a 6 millimeter lesion instead of a 6 centimeter mass. We need to have a role to make sure that the patients are being looked after and the technology is being appropriately studied. And I don't know what's going to win out. I try to check my biases, but I think we have to be at the table. What this did, we're now over 10,000 lives that we screened off the bus, not the hospital, from the bus. And these are people that were sitting at home, disengaged from healthcare. Most of them don't have a doctor. I'm their doctor. And you then put yourself in the line. If you want to do the ions or the navigational biopsies, you can do them. It's well within our scope. We're great at actually doing them, but you're in the decision making process of what's the best thing for their lung cancer. I'm afraid the further we get away from it, the patient's not going to be benefiting from that. There's too much that's going to happen these next decade or two that we got to be there. So this kind of, it helps the thoracic surgeon in so many ways. It helps the patient at risk for lung cancer in way more ways than I even thought.
That's great. Now, on the bus, is there a nurse practitioner who is on the bus?
So all this world's changed. So when we started out, it had to be for the shared decision making. We now do that through a teleconference, a video, or by phone. There's ways of doing it and getting it done. The nurse practitioner we've actually taken off the bus. And when you're now managing 10,000 people and you've got a bus that can only do 3,000, how do you keep them going and in their annual visits? It's complicated. And then if our goal is getting into the 25, 30,000, there's a lot of technology and management. That nurse practitioner is the fail-safe stopgap. I'm responsible as a surgeon, but it's really, I need him to be on charge, and we may need a second one. On the bus is a driver, a registrar, and we tried to have the driver be a registrar, but they don't type well. It's just different skill sets. So the registrar that can work the computers, knows Epic, knows their registration system. All they do on the bus is they're going to check, make sure it's the right person. They're going to sign the HIPAA compliant text messaging forms. Then there's a CT tech. What's coming is now you have fully automated CT scans that can use that CT tech in a different role, and she may or may not need to be on the bus. And there's so many future things to lung screenings and iterations that it'll keep evolving. The real burden of your salary, wages, benefits, the cost of running a program comes back to that office of how you manage those 10,000 people that we have now, getting them back in for their annual compliance. And we struggled. Mailing letters didn't work, phone calls, you have to have a call center to manage that. And they don't answer on the first time because they don't know why you're calling them. And it was logistically impossible. When we started doing the text messaging, even my mom, before she passed away at 86, 87, would answer text messages. May not answer the phone, but look at the text message. So our compliance went from 35% annual compliance rate to 76%. And, I don't think it's always a constant challenge, but most of your people are going to be back at your home base getting signed up for the next event. We learned we don't go to event without having a significant number of people already signed up. But that's what comes with maturity. If somebody walks up, we'll still screen them, but we'll use a telehealth method to use the people back at the office instead of disrupting the bus and the people going through that short visit. So a lot fewer people than we started out on the bus, a lot more people based at the hospital, helping out the process. That we need more technological innovations and automations to make it scalable. But
That makes a lot of sense. It certainly increases the efficiency. For our listeners out there, when Dr. Hedrick is talking about text messaging, he's talking about his team text messaging patients to remind them about their follow-up. And because that's a major component, a major issue in lung cancer screening is not necessarily the first screen, although that is also very challenging. It's the follow-up scans of the annual screens. And it's really impressive that Dr. Hedrick's team has a 76% adherence rate, which is well above the national average, which according to the American College of Radiology is around closer to 25%.
the thing that it also gives you, Jeff, is as we did, it always leads to something else. There's ways of interacting besides, anybody with a significant finding still gets a phone call, and that's 10% of the patients. But if I can tell you 2 hours after you got off the bus, you don't have lung cancer, your calcium score is 0. Great. Go to my chart if you want all the nitty gritty details. We'll see you in a year. But now there's opportunity of getting on smoking cessation and communicating with them. And you've got this trust built up, and then you become almost a health coach that can kind of address things. It helps with the compliance of how to get them back in. And that saves people and time because you can automate that pretty easily. And it's not a real expensive tool to have the HIPAA compliant text messaging component.
That's great advice and great insight for all of us. I'd like to talk about some skeptics, and what you hear sometimes is it costs too much to do this, to have a mobile lung cancer screening program. And what's your response to that?
Unfortunately, the data that we currently have tells us it costs too much to ignore lung cancer. And it's really easy to put against it. So even when the early discussions of you're going to go out and find people who don't have insurance, I go, yep, I will. They're still worth helping. That's just we're a faith-based hospital, but financially, what's that impact to us and can we survive it? I go, I can't make lung cancer go away. So it's occurring in our population at this prevalence rate. And if we're the lung center and the cancer center that they have access to, they're coming here either way. Don't you want them stage 1 instead of stage 3 or 4? It's to your best interest. And I go, and I bet a lot of them actually qualify for help. They just don't know. From a started out 18, 19% survival of lung cancer, the amount of cost of care, but it's not just the cost of the medical care. The whole family gets pulled out of that from their workforce. The impact to our state, I think it's $750 million per year in out of pocket for gas, food, run to the pharmacy for a medicine, Tylenol, something for diarrhea that's in that journey. And then for 2 years, you disrupt what's important to every governor of every state, your workforce. But if there's kids also in the middle, it disrupts their life. The impact is way greater than even the economic piece. And I go, we've got to be willing to fail to do something different. In the end, what happens is, and hospitals hate about downstream revenue. Everybody wants to claim credit for everything they've done. Because this is probably the best model because we're going out and getting people who are not coming to the hospital. They've given up on healthcare. They've given up on me as a physician. They are not symptomatic, and I'm just going to wait this one out because if I'm not hurting, I must be okay. And you're re-engaging them at a point you can truly alter their cost of healthcare. If somebody already has lung cancer and heart disease, I can't change that. If they don't know they have it and they haven't had that event yet, the benefit we can change to the cost curve of healthcare for the majority of what causes our complications and costly care in healthcare is the heart and lung. What a humongous opportunity to the payers of healthcare and to the patients themselves. So the downstream revenue of what you find pays for the bus. It more than pays for it. So the number one requirement from the donor and from Governor Lee of Tennessee, when I talked to him about it, I'll give you money once, but I won't give you money more than once. You have to prove to me it'll stand on its own. So Rob Hedrick cannot own a bus and survive. I'd be out of business unless I charge an exorbitant amount of money for the scan, which won't work. But if I attach it to a cancer center and that cancer center is managing the patient as we should, doing good, not just for the lungs, but everything that's on that chest, and being a health coach to them and being more preventative minded as far as our health care, it more than pays for the bus. It actually creates a generous profit that goes back into taking care of more patients. So it's a win. I've never seen anything in my life in healthcare that was a win. The technology is the right timing for the AI tools coming out, all the things to make this possible. I would have failed 20 years ago doing something like this. The patients definitely win. Our state economics win. Our healthcare payers win. There's just, I can't find a loser in this. So sure, we'll make wrong decisions. I've made tons of them and things that I just wasn't aware of. But I think willing to get out and do this, make the mistakes, it has to be something better than what our current state is of how much money is going into lung cancer, the poor outcomes, and the impact of families. I know one of the things I'll say briefly, when my mom was getting ready to pass away, I was asking her certain things that she wanted me to leave for an individual. And it was quick that I realized she didn't have much. And her comment to me was, you don't know how expensive you were. But she goes, look at that closet. And there's tons of pictures that she had. She goes, that's my treasures. To lose somebody, not even a physician, but anybody age 50 or 55 or 60 that you spent so much in their life and has so much value to commit back to our society is a gigantic loss to that family who maybe there's teenage kids they're raising. It will change that family forever. I just sat there and I go, we can't let people in this age group we've invested so much in that have such a critical role of running a family, running a business, running a church, running something. When we lose those individuals, it truly throws our country to uh, a poor state of health overall, economically, physically, mentally. And this is too big of an opportunity that we can make a difference. And maybe it's a crazy bus on wheels that has some small role in just getting people talk about it. I'm convinced the thoracic surgeon out of the operating room can solve this and many more problems in our federal government. We just got to get out of the OR.
That's very well said, and just incredible, very inspiring. And I think we have time for one last question, which is, can you talk a little bit about your work with the STS in advocacy, and also what the STS is working on right now? I know that
Yeah.
STS is really dedicated towards advocacy, specifically for lung cancer screening with the
Yeah.
Increase in Lung Cancer Screening Act, and then also trying to get funding for people who want to start mobile lung cancer screening.
So one of the things that will frustrate everybody about DC, if you spent time there, it just works at a different pace. And I don't know that's bad. It's just frustrating. So our founding fathers meant for things to be hard to change our government. It should have to get bipartisan support, not just one person on the other side. Good ideas will float themselves. But there's a lot of complexity that businesses don't have to do, hospitals don't have to do, and thoracic surgeons get easily frustrated with it. One of the people advising me and coaching me said, remember, it took 15 years to get Medicare to pass. Something we seem like, how could that be so hard? It passed by a fluke, and just the planets were aligned. One of the things that I saw, we're great as a advocacy group of signing on to all the things that matter, but there are big issues that are slow to change. It may take 10 years to happen. We have to do it. We have to sit there. I go, what can that DC office and what can our health policy office actually do to help our members with whatever their mission? If it's congenital heart disease, how do we do something that they're passionate about and get funding for them? There's a lot of grant money and opportunities in DC. You just have to know the pathway to get it. And I don't think we were accessing any of those opportunities. So getting our membership to say, hey, I need help with this. It'll help me. It'll help my program. It's going to help the people in Boston and people in New York, people in Tennessee or Alabama. I wanted our office to show it has a bigger role than just signing on to the big policy letters. So the mobile piece was, I had so many people coming to me that were asking for help. I go, I'll help you. I'll go to them. I'll give a talk, but I'll go talk to your donors. This is something so easy. And then it became, I can't fly all around doing it. How do we make it much more systematic? So we want to introduce legislation that creates grant funding through Health and Human Services, or a place within the government that funds people. You show the reasons you need it. It meets the criteria, you get money. There's lots of other through ARPA-H and different pieces of our federal government. There's a lot of money that is actually focused towards these types of initiatives, but the application process is unique, different from what we've done. It's awkward and weird, but Derek in our DC office knows how to do those things. I wanted to try to connect those opportunities to our membership. So we see more of why you should be given to the PACS system, our PACS fund. Why should we be participating and caring about Washington? I think we've neglected that piece of it. And maybe if I can be successful, we have a different way of how what I did on my own, but can translate to so many other ideas we have as cardiothoracic congenital surgeons, and how we can help people. Everything requires funding and money. And there's a lot of it in Washington. We just haven't been good at accessing. We have the good reasons to use it. We haven't been good at the politics of how you have to go about the application, the process, the legislative ideas to make it happen. So changing a little bit of the focus towards that, and hopefully we'll have some success with the lung screening piece of it.
Thank you very much. Today's focus is on mobile lung cancer screening and your work in that area, but I know you've done so much more in health policy reform and advocacy. So we'd love to have you back next time to learn more about your experiences and your work in that area. I'd like to thank you again, Dr. Hedrick. It's absolutely inspiring what you're doing. So few of us are actually doing mobile lung cancer screening, and we need to do more. More of us should do this, and we're going to follow your lead and learn from your experiences and your recommendations. And best wishes in this next year for you, and hope to continue to get these amazing updates about your Breathe Easy truck and your mobile lung cancer screening program in the future. Thank you.
You're welcome. It was an honor to be here with you.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.